Right. So we're going to start very soon, but whoever is here, welcome to the first webinar in this series on managing quality of health products throughout the supply chain. This webinar is hosted by SAPIX, and it's a joint collaboration between SAPIX, B-Skilled, Ecumenical Pharmaceutical Network, EPN, CM Comms, Quality Assurance, and of course, International Association of Public Health Logisticians, IAPHL, the one of the longest serving public health logisticians network. We will start in a minute's time as the room fills up. I would also like to inform everyone that this webinar is being recorded. Yes. And the webinar is also accredited for CPD. Anyone who spends a minimum of 70 minutes in the webinar will receive 2 CPD credits and a link to download the CPD certificate. So the link for the CPD certificate will be sent to you after the webinar, provided you have spent 70 minutes in the webinar. Vinita, do I have slide controls? Or maybe
Yes.
just go next. I don't see anything, so if you can click next. Yeah, and please check if you can give me slide controls. Okay, so what is this webinar series about? I was reading a post which was shared by IAPHL's executive director, Timmy, um, which was about the Ebola epidemic in DRC, and about $580 million were being allocated by WHO and many other development organizations to fight the disease. Uh, as you all know, across Africa and other emerging economies, donors, ministries, NGOs, FBOs, they allocate a lot of money in procuring and moving medical products through the supply chain. But we know that a lot of these products which reach the end user are either substandard, and a lot of time they're also falsified. Falsified meaning they are fake. So this is a very big issue. I also read last week that on a daily basis, 1 in every 4 products which are tested for quality in Africa, they fail those quality checks. 1 in 4 means 25%. And I found it extremely distressing. And I hope you do too. So, this webinar series is an effort where 5 organizations who are very passionate about supply chains and the quality of products uh, moving through those supply chains, we are going to convene experts from Africa and beyond to discuss, showcase, and identify these crucial quality assurance problems with health products across Africa. And we will attempt to formulate certain actions and inform everyone and provide a list of quality management competencies for health and supply chain professionals working at all levels within sub-Saharan Africa. As you see, today is the first webinar where we are going to present the problem. The webinar is titled Weak Quality Management Disrupts Gains Achieved in Supply Chain Strengthening. And that is the frame for today's webinar, that we are putting a lot of money into supply chain. But if even after that, if the end product which reaches the patient is of poor quality, then we really need to be alarmed. In the upcoming months, uh, we will focus on different issues of quality assurance within the supply chain, which is about understanding where quality breaks down. Sorry, can we go to the previous slide? Okay, yes. So where does quality break down? The role of different stakeholders, including the regulatory authorities, such as the regulatory authority of each country, and the newly established AMA, African Medicines Agency. At In the last webinar, we will try to move from awareness to action to understand the accountabilities, to understand what advocacy is needed and what skill sets are needed. Okay, I need to go to the next slide. I still can't. Okay, all right. So for today, this is the agenda on your screen. It is going to be a very interactive webinar with different polls, quizzes, and reflections. And the webinar will begin, the technical part of it will be led initially by Mr. Collins Jaguga, who will present the problem. Then, as Collins finishes his part, we will invite a panel of four experts who will go deep into this and talk about the root causes, the implications, the consequences of poor quality products across different regions of Africa. Then we will take questions from audience, and this reminds me that the chat box, um, no, sorry, chat box is for us. I believe there should be a Q&A for you where you should be able to write your questions, Connor to confirm. And after the Q&A, there will be a webinar summary and the linkage to the next webinar, which will again be presented by Mr. Collins Jaguga. And at the very end, I will invite Mr. Bongeni from CEPIX to present a very key upcoming event for everyone. So moving on, I would like to introduce the organizers and the speakers. So CM Comms is an African-led organization strengthening pharmaceutical and health supply chain quality assurance across Africa. While they are based in Zimbabwe, but they are an African institution. EPN is a Christian international non-profit institution improving access to medicines and pharmaceutical services in church-based health systems. They are based out of Kenya. We all know IAPHL is the oldest global professional organization promoting public health logistics through education, networking, information sharing. B-Skilled is the global provider of competency-based e-learning programs for health professionals based in India and the United Kingdom. And finally, our host for today, CEPIX, the oldest supply chain networking organization across Africa, registered in South Africa, and they are the premier supply chain professional development institution in sub-Saharan Africa and beyond. These are today's speakers. My name is Sanjay Saha. I'm the founder and CEO of B-Skilled. I'm also a health systems expert. We have on the panel Mr. Collins Jaguga, Dr. Boniface Funda, Dr. Joseph Murillo, Wilson Chandomba, and Timi Amole. I will go through their bio as I invite them to the podium. Yes, next slide. Now, before I invite Collins, there are two more slides that I have. The first one, I would like to bring your attention to the pre-webinar discussion, which we had organized as part of the registration, where we had asked two questions to all the participants. Question one was, what is the point where product quality is at most at risk? And question two was, what is one question about product quality that we're not asking? The responses were varied, but I have summarized them. And most participants are saying storage and last mile transport are the point where product quality is most at risk. Questions that are not asked: who is accountable? How much of quality issues go unnoticed? And we only see medication failure from a patient's perspective. And finally, what is the socio-economic cost of poor quality? Some members also pointed out the weakness in infrastructure and processes at the point of care. If you still want to participate in this discussion, it is still live. Vinita, if you can paste the link on the screen in the chat box for everyone. Maybe probably later. Let's go back. Yes. Okay. So before I invite Mr. Collins Jaguga for the keynote, I would like you to join this poll. You can scan the QR code or go to slido.com and then type 2464963. I would like you to think about in your day to day work, how close are you to managing the quality of medicines moving through the supply chain? You will find some options in the poll, and you can select one option out of the four, or rather one option out of five, and then we will see what is the distribution of the audience for today. We have started to receive votes. We have received two votes. So I would request everyone, we have close to 100 participants. If everyone could scan this or go to slido.com and type in 2464963 and participate in this introductory poll. Now, uh, while this poll is going on, let's go to the next slide. I would like to uh, introduce Mr. Collins Jaguga, who will frame today's problem of poor quality medical products circulating within Africa. Next slide. Mr. Collins Jaguga is a public health and pharmaceutical systems specialist with over 22 years of experience across Africa and Asia. He supports governments, donors, and health institutions to strengthen pharmaceutical systems, including supply chains, regulation, and antimicrobial resistance. He holds a bachelor's in pharmacy, MBA in healthcare management, and a master's in global supply chain management. So we have invited Collins because he sees the world from different perspectives, from the perspective of a pharmacist and also from the perspective of a supply chain manager. He has worked across multiple global institutions from EPN to MSH to uh, United States Pharmacopoeia to IQVIA. And these days he's working at Pharmaceutical Society of Kenya. Um, I think the poll is going well. So if anyone has not done it, I would request you to please participate in the poll. And with that, I would invite Collins to present today's problem in more details. Collins?
Uh, Thank you very much, Sanjay. I hope you can all hear me. Hello, everyone. Thank you, Sanjay, and the organizing team
Yeah, Collins, we lost you suddenly.
for this privilege, this talk. So just to start us off, am I audible now?
Yes, yes. Please go on.
Okay, thank you. So just to start us off, in this webinar series, so why does quality matter? Why is it in our interest to be concerned about quality? And there are two case studies, very short case studies here that I'd like us to go through. So the first one here is where a child receives an antibiotic that contains insufficient active ingredients. It goes without saying the infection worsens, the family spends more money seeking care, the healthcare worker, of course, loses confidence in the medicine. The pathogen develops resistance, and what initially appeared to be a medication problem has now become a patient safety, health systems, and
Yeah, Collins, I'm sorry, we are losing you.
health problem.
Yeah,
Next
Collins, I'm
slide,
sorry we lost
please.
you. We lost you in the last a minute. Your voice was not audible. Could you check your connection?
Um, sorry about that. I don't know what. Um, can I?
Oh, okay. So unfortunately, this is sometimes it happens. Technology is not in our favor. We will just wait probably a few seconds for Collins to come back. Um, but
Sorry, my sincere
okay, you're
apologies.
back.
Am I audible now?
Yes, yes, you are.
Okay, okay. My
Please
sincere
go ahead.
apologies for that. Now, so this second slide talks about diagnostics. So where we have a patient with tuberculosis tested using a substandard diagnostic test that produces a false negative result. As a result, treatment is delayed, the disease progresses, and the patient continues transmitting infection within the community. So again, just like the antibiotic case, what appeared to be a diagnostic quality problem has become a patient safety and public health problem. So in other words, there are a myriad of consequences when quality is not considered. It's just beyond poor patient outcomes, but it leads to increased hospital stay, increased cost of care. It becomes a public health problem. But what do we really mean by poor quality medical products? Yes, we talk about medical products. So WHO has three categories of medical products: substandard, falsified, and unregistered or unauthorized. A substandard product, like most of you would be aware of, these are authorized medical products that fail to meet quality standards or specifications, right? So this is a case where you have a medication, like I've indicated there, that contains, let's say, only 70% or 60% of the stated active ingredient, or a cold chain product that is degraded due to cold chain failure. So often these are approved, registered products, but there's a lapse. There's a quality defect that may have occurred either during manufacturing, storage, or even during transportation. The next slide. Falsified products is the second category of poor quality medical products according to WHO. So these are products that deliberately or fraudulently misrepresent the identity, composition, source. So often these are manufactured by criminals or ill-intentioned people. You may have an antimalarial that contains chalk instead of the ideal active ingredient, or a medication that has a fake batch number or even wrong manufacturing details. So here the key issue is that the intent was to deceive right from the word go. The packaging may be wrong, the labels may be wrong. And so this is what we mean by a falsified medical product. And this is also a poor quality medical product. The next slide, please. So this last category of unregistered products, and that terminology is self-explanatory. So these are medical products that have not been evaluated and are approved by a competent, relevant regulatory authority in the market in which this medical product has been found. And it's important to note that unregistered products may or may not be of good quality. Yeah. So you may find a product that has been registered in country A, right? And this product has found its way in country B. So it may be a good quality product. However, in country B, a competent regulatory authority has not assured the quality of this product. So in such a case, WHO defines this as well as a poor quality product. But now, having defined what poor quality products are, substandard, falsified, and unregistered. So how would we define a quality product? So if we could just go back to the slide, just back to the slide, that the previous slide. Yes. So for the purposes of this presentation, so there is a working definition that I've written down there where a quality assured medical product is one that is authorized or registered by the relevant regulatory authority and consistently meets approved standards and specifications for quality, safety, efficacy, and performance throughout its life cycle. So that is all the way from manufacturing up to the patient. Thank you. Next slide, please. How big is this problem? And I think I had Sanjay mentioning some statistics in his introductory remarks. So there's a study that was done by Mekonnen et al. That talks about 22.6% of medicines tested failing quality standards across 27 African countries, that covered about 7,000 samples. So this tells us that about 1 in 5 of the medicines in Africa could fail one or two quality standards. The World Health Organization talks about 1 in 10 medicines in low and middle income countries being found to be substandard or falsified. And WHO again mentions there that 42% of global substandard and falsified medical product reports received between 2013 and 2017 came from the African region. And this could only be a fraction of the real problem, a fraction of the poor quality medical products that are in Africa. When I was preparing this presentation, I thought to myself, whereas this 42% could be alarming, it's also good to note that there is reporting on the African continent, because it's one thing to have poor quality products, it's another thing for us to be reporting. And I think it is good that there is increased awareness and that there is increased reporting of poor medical products from Africa. Now, which medicines are mostly affected? Unfortunately, WHO has found that largely we have antibiotics, about 5%, of the reports, antihypertensives and antimalarials. Antihelminthics there, that figure at 61% needs to be taken into caution because the sample size there was small. And then there's a study for anti-diabetic medicines that was done and published last year that indicated that 28% of anti-diabetic medicines were found to be substandard, were found to have failed at least one quality standard or two. So this is just to tell you that these are the medicines that are mostly implicated when it comes to poor quality medicines. And unfortunately, these are the medicines that target, a significant proportion of the diseases or the ailments that are found in Africa. Next slide, please. But where does quality actually fail, right? It's worth noting here that quality can actually fail along the supply chain, all the way from manufacturing up to the patient level. Many times we do not think about medicines in the hands of patients, but along the chain from manufacturing, even up to the patient, our quality can fail, or there can be lapses in assuring the quality of medicines or managing medicines. So at the manufacturing level, you may find a GMP failures, there can be contamination, there can even be deliberate falsification at the source, use of a wrong active ingredient or an excipient. At the import and customs level, there's generally limited inspection, at our ports, at the seaports, at the borders, and the cases where products that are on transit, from one country to another could end up being diverted and being used locally. So these are areas where, poor quality medicines can be introduced, or there can be suboptimal assurance of the quality of medicines. During wholesale distribution, there's a risk of substandard or falsified medicines or medical products, getting mixed with products of good quality. So these are areas along the supply chain where quality can fail, or where there can be lapses in assuring the quality of medical products. Storage and transport, I think this is very, very common in low and middle income countries and even in Africa. Temperature excursions during storage at the seaports, in our warehouses, Cold chain lapses. I have visited warehouses whose temperatures were 40 degrees, as warm as an oven. And, trucks are coming and picking medicines and taking them to the various healthcare facilities. Last mile dispensing is also an area where, the quality of medical products could be compromised, use of unlicensed vendors, street vendors, and like I said, even at the patient level. Quite often, pharmacies, healthcare providers do not educate patients how to store medicines to ensure that the quality is guaranteed during the time that they're taking their medicines. Next slide, please. Now, what are some of the root causes of poor quality medicines, right? So this slide attempts to categorize the root causes in four broad areas: regulatory lapses, supply chain weaknesses, market factors, and governance failures. As most of you may be aware, we have about 9 African countries that have attained WHO a maturity level 3, right? We do not have a maturity level 4 yet in Africa. I think Zimbabwe is close to, but is currently pursuing. So that tells you that over 80% of the countries in Africa have lapses in their quality assurance mechanisms. Yeah, lapses in ensuring that the medicines that Africans receive are of good quality. There's limited lab capacity. There's generally weak post-marketing surveillance and reporting systems. And so these are areas that, if strengthened, would ensure that the medical products that are consumed by Africans are of good quality. So strengthening our NRAs is a key, and that's, of course, a root cause of our poor quality medicine. Supply chain weaknesses, again, goes without saying. Fragmented supply chains, poor traceability. I know a few countries here and there are coming up with GS1 standards. I think Uganda came up with a strategy the other day. And just by the mere fact that in Africa we import over 80% of our medicine, we are largely import dependent. And the fact that there are long international supply chains, it goes without saying that there is a risk, quality could be compromised along this long supply chain. We have talked about poor storage and poor distribution. Market factors, medicine shortages and limited access. When these fraudulent manufacturers hear that there's a shortage of this medication, so that is an incentive for them to increase the production of these medical products that are falsified and get them infiltrated into the market. Governance failures, including weak enforcement on the import of APIs. I do not know how many countries, how many manufacturers really ensure that the APIs that they are importing are of good quality. Corruption and weak in enforcement, and even cases where people have been found with poor quality product, criminal incentives, etc., etc. Next slide, please. So finally, what is the patient and economic impact of poor quality products? And there's a modeling study here that was done in Nigeria for children under 5, right? That was to estimate the patient and economic impact of poor quality antimalarials. And it was found that this could potentially lead 12,000 deaths annually, and this is in addition to those who will have naturally died, probably from other things alone, would potentially lead to over 12,000 deaths, would potentially costing about $892 million in annual economic losses, would potentially lead to about $30 million in direct costs, right? And by and large, about $852 million in productivity losses that is both short-term and lifetime productivity losses. So you can see the economic impact is enormous. Yeah, so if we do not do something about it, this model tells us that the cost is grave. It is your child or my child that could be in this statistic, right? Next slide, please. And finally, just to mention that this study also estimated that the emergence of resistance reducing SCT effectiveness, that is artemisinin combined therapy, could add approximately 839 million US dollars annually to Nigeria's malaria economic burden. I mean, these figures are staggering. With an additional 7,000, almost 8,000 deaths among under 5 children seeking malaria treatment in the model scenario. So these are model estimates, not directly observed, but they demonstrate this and resistance interact. Thank you very much for listening to me, and over to our moderator, Sanjay. Thank you, and over.
Hi, Collins. Thank you so much for managing with the internet. I hope most of it was audible to our listeners and listeners in the audience. So I think we have provided a great amount of data on what is the problem. So you can go to the next slide, Vinita. What is the problem? What are its impact? What are the root causes? So we have gone deep into defining this issue of quality, more specifically within sub-Saharan Africa. Now, just to check that all of you are actually listening on, and not sleeping and not have not joined this webinar just to get the certificate, there is a small quiz. Um, as you scan the QR code, you will reach Slido again, and you will see there are three questions which I'm going to switch on in series. So for each question, you're only going to get 20 seconds. So I'm going to switch on the first question in the next 5 seconds. So you should get out your phones or go to slido.com. Again, the code is the same 2464963. And here is the first question getting activated. And you have 20 seconds to answer this question. And it is a quiz question. So it is live. So please check and answer. Very soon, this question will go off and the next question will be on. And at the end, we will see a leaderboard. So there will be a leaderboard to see who has answered all the questions right. So the next question is on now. So if you have missed the first question, very unfortunate. But now the next question is on. Okay, very good. Lots of votes for the second question. All right. And finally, here is the third question. Yeah, I see some votes going on. And I will be sharing my screen very quickly to show the final leaderboard. And here it is. Okay, stop. Okay, where is the leaderboard? Leaderboard, excellent. Okay, something wrong. Mhm. Okay. There is some technical problem. I see the leaderboard, but I'm not seeing everyone's score. So let me try to find it and post it as we move along. But I think many of you have answered the questions. So I would move to section 2, which is a panel discussion. So we have four panelists, four experts who, in all fairness, have worked almost 15 to 30 years within Africa and beyond. And they're going to talk from their experience how they have found the quality issues at national and regional levels within Africa. To get this started, I would like to first invite Dr. Boniface Funda Funda. Next slide, please, Vinitha. Uh, Dr. Funda Funda is a pharmacist and has a PhD and an MBA. He has 30 years of experience in public, private, and NGO sectors across Africa and Europe. He's currently a board member for SAPIX. I know Dr. Funda Funda when he was the managing director at MSL Zambia. And since then, he has gone on to work for various international organizations. His last appointment was with Africa Resource Center, where he was the co-CEO as well. So, Dr. Funda Funda, if I can ask you, um, what are the consequences of falsified and substandard medicines for public health systems within Africa that you have seen during your vast experience working in different countries and with different institutions?
Thank you, Sanjay, and thank you everyone for certainly inviting me and also enabling me to participate on the panel. I think based on what Dr. Juga has just mentioned, there's quite a lot of observations that I've seen, which largely fall around the issue of trust and confidence in the public health system. You can imagine, as one of the slides showed, where poor quality products that have been found in the supply chain have been admitted to a patient will result in the death of that patient. And there are many examples of this, and they cut across the whole continent where we are. And so what you find is that, there tends to be a lack of confidence and trust in the public health system. And as you know, largely our continent depends on public health that is free at the point of care. And many of our citizens benefit from that free public health system. And so where compromised products are in the supply chain, there is a problem of confidence and trust in that public health system. And this might sound simplistic, but or a given, but in fact, that is the reality that we're dealing with. And it's not something that we can bypass. So the whole system is compromised, is seen as such, and the public don't trust it. And you end up having very poor trust and confidence even in the institution that is, first of all, buying the products as well as managing the supply chain. And you also have lack of confidence even in the manufacturers of these medicines, because quite often this is public information about where products are coming from. And if those products are certainly also mixed up with falsified products, the public generally just takes everything as one lump, where all these products are being present and given to patients. And so you end up with the source of medicines, the supply chain, all of these are compromised. And you have a very, very angry, obviously, public health, or rather citizenry in any given country. And one of the things that obviously happens is that the public health system begins having to fight this situation by obviously having to re-procure or procure again more medicines. Try to even find new sources, try to understand what is happening, what is causing all of these problems of poor quality, poor safety, and so forth. So you find that the health sector budget just shoots up. And that's something that's not sustainable for any government. And it's not just the buying of medicines, but it's also the resupplying of these products in our country. So that's something that is very basic. And I think it's something that we just need to acknowledge, that as the mere fact that, these poor products are found in the system, the whole public health service is compromised. And the whole profession of public health is affected whether it is you are dealing with diagnostics or it's medicines. So that is really the essence of what is the first observation I would say around this problem. Over to you, Sanjay.
Thank you, Bonnie, and I think that's a fair call. But I think I would now move beyond the systems, and I know there are a lot of and we saw in the poll, saw in the poll, and there are lots of pharmacists, practitioners, physicians, supply chain management practitioners, probably nurses, who are in the call. Now, as experts, how do we understand these consequences for a pharmacist when they don't have visibility of the entire supply chain, or for a nurse who's working at a community health center, or for a doctor who's working at a district? So, how do they understand these consequences without having the full visibility of the system?
Mm-hmm. And that's a good question. And I think part of the challenge we have is that we have functions that are quite vertical, even within a public health sector setting. And particularly when you look at access to medicines, enabling access to medicines, whether it is procurement or supply chain, that is still seen as fairly vertical in the way their functions are provided. But listen, I think if you look at the fact that you've got nurses, doctors, clinical officers, community health workers, you've also got pharmacists. If all of these people can see themselves as part of the supply chain, right? They can see that they have a role somewhere along the supply chain. They play a role, whether it is the people planning and forecasting, and the people buying, those people who are receiving goods, processing them through a quality assurance process, storing them in warehousing, and then putting them onto a transportation system that delivers to service delivery point, to the people who receive, put them in the hospital stores, and to the clinicians, and lab diagnostic technicians who have to use the products on a patient. If they can see that those are specific roles that they play, but they are part and parcel of that whole supply chain. So I think some very basic things needs to be accepted. Indeed, that the pharmacists, certainly as custodians of medicines, and quite often, medical devices and other consumables, just having an appreciation of what is your responsibility in that role. What do you understand about your role as custodian of medicine? What does that mean? Where you look at forecasting, planning for the procurement, planning the storage, and so forth. What do you know about all of those aspects? How do those things fall into your day-to-day tasks that you perform as the custodian of these health products? How do you ensure that you are managing the products safely, whether they are going to go on a vehicle, what sort of a vehicle are they going to go on? Is that transportation system suitable for transportation of those specific products? What is the appreciation about the accountability you hold as the custodian, right? And you then pass that also on to the users. By this case, I mean the clinicians, whether they're nurses or they're doctors. What basic knowledge do they have? Do they know about what are the requirements for keeping medicines within the hospital infrastructure, whether it's on the ward, in the theater, or in the lab, in the lab. And I think to that you can add what sort of education and support is being given from the hospital pharmacist, whether it is certainly at the hospital level, but also at district, province level, to try to educate all these colleagues in terms of being responsible and having clear appreciation of what are the requirements for managing and providing these health products to themselves as clinicians, but also definitely to the patients. So without having to turn them into full supply chain officers and so forth, what you want is people to just simply know that these are the requirements. And then certainly, the lack of visibility, of understanding and the appreciation of where the goods are coming from, what's happening to those goods along the supply chain up to the time that they receive them in their hands. That is a problem, and it's quite often would have been seen like it was a difficult problem to sort out. But in fact, nowadays we've got so much technology that can provide you visibility, that can show you where things are coming from, how they're being handled, and what are the requirements for this particular product. By the time you receive it, you need to have that assurance that the product is of high quality, that it will be given to a patient in that state, rather than full of doubt as to whether this is actually going to work, because I don't know where it was stored and how it was handled along the supply chain. So I think that is the issue that we have and that we have to face. That besides just the technical things that we are very happy to talk about, the pharmacovigilance issues, and just, storage issues, I think there's that requirement to play a role and being very clear about what is my role on a daily basis when it comes to management of medicines, whether I'm the transporter, whether I'm the warehouse manager at a central medical stores, whether I'm the person receiving to use on a patient. What are my responsibility? You cannot detach yourself from all of that, because we are all part of this whole supply chain. Yeah. Over to you, Sanjay.
That's a great reflection as well, Bonnie, and I hope your words they echo at least around this room. I think it all boils down eventually to taking accountability at a personal level and trying to understand how everyone's actions affect the system at large. And of course, something that I'm very passionate about, learning and learning and learning, always learning about these things. So thank you so much, Bonnie, for sharing your views. And from a more pan-African views, we would like to go slightly towards understanding things at a more regional level. And I would like to invite Mr. Wilson Chandomba, who is an implementation assurance specialist, which means that there are lots of policy, there are lots of guidelines, but how do you know whether those things are implemented accurately or not? He has been a quality assurance expert and a certified supply chain leader for over 28 years across health supply chains in Africa. He helps organizations generate objective evidence that quality systems are functioning effectively and delivering the outcomes they were designed to achieve. He currently leads CMComms. And Wilson, I have a very interesting question for you to start with. While we focus a lot on quality of finished products being imported in Africa, and I saw some chats as well around that. And we do that through GMP inspections, quality certifications, lab testing of imported products, and these are all finished products. But how would you characterize the quality of locally manufactured products in Africa? What are some of the key factors that affect the quality of locally manufactured products? Because we're not really talking about that. And I really want to focus on the quality of locally manufactured products in Africa. Wilson, over to you.
Thank you, Sanjay. Thank you, everyone. Thanks
Wilson,
to Collins.
Do you mind
and
putting your camera on?
Yes. Am I visible now?
Yes, please go on.
All right. Thank you very much. Right. When we talk of local manufacturing, I think there is one critical aspect when we talk of quality and quality assurance. Quality assurance, by definition, is the totality of everything that happens. And I've seen mostly we focus probably on regulatory issues, but it goes beyond that. But I think one other area that is critical is actually the movement of formulation ingredients. Here I mean the active pharmaceutical ingredients and excipients. We've got a standard called Good Trade and Distribution Practices, which focuses on the movement of active pharmaceutical ingredients and excipients. And a few countries, if not, they have not had this standard, even having it and implementing it. Remember, you cannot test for quality. Yes, testing is important, But remember, testing is only probability based. I'll give a good example. When you are manufacturing, let's say, sterile manufacturing, let's say it's a atropine injection, and you are manufacturing 100,000 ampules. When you receive the atropine sulfate, let's say it's 10 kegs, you cannot immediately sample it because it's a sterile. Then assume you do 100% sampling on manufacturing now in the sterile plant. But what about the 100,000 ampules? You can only take a sample. Let's say you take 50. What about the 99,500? Because they are expected to be all sterile. So the basis for quality assurance is quality by design, where we talk of you build quality into manufacturing at every process, and it becomes incremental. So for local manufacturing, the most important aspect is how do you receive your active pharmaceutical ingredients, and how do you also do your sampling, because the three biggest challenge in manufacturing is contamination, cross-contamination, and mix-ups. So those are some of the key aspects in terms of ensuring that quality is managed at every stage. And when we put it as a percentage, the majority, I'll say 90% of quality is incumbent upon the manufacturers. Over to you, Sanjay.
Yes, sorry. Connor, can you check? I'm hearing something I can't figure out from where it is coming. Wilson, you can continue. I'm sorry. It was not me.
All right. So for manufacturing, when we then talk of implementation assurance, right now we have got a bit of a challenge where we are working smarter because of the tools, especially AI. You can actually do in a few minutes or a few seconds, you can do a quality manual, you can do SOPs, you can even do temperature mapping through a machine. Yet on the ground is different. We need, one, to be ethical, two, to really understand the reasoning behind certain processes. Because a medicine is a controlled, another crude definition of a medicine is controlled poison. That's why, for example, we say paracetamol 500 milligrams. If it is beyond that, it becomes dangerous. So we actually need to ensure that we follow and implement to the latter the available standards, GMPs, validations, qualifications, especially now where tools we have. WHO is now insisting, for example, on quality control. They are now insisting on an auditable laboratory information management system, because with AI, it's easy to manipulate results. So I think the most fundamental issue is we are responsible for what we do, and we need to do it ethically, because quality cannot be tested. You are only taking a sample. What about the other products that you have not tested? What is their quality? So we need to really be ethical and protect our citizenry. It is actually a call of duty. I think that's what I would say, especially in terms of local manufacturing. Let's manage our how we receive our raw materials and the sources of the raw materials. Rather, let's focus on pre-qualified suppliers of active pharmaceutical ingredients and excipients, and they have to be registered and audited such that we at least assume, and we have evidence that we are buying from a supplier whose quality system is not questionable. So I think for now, that's what I would say in terms of local manufacturing, and obviously implementing GMPs.
Yeah.
You see,
Wilson,
regulators, they only come. Yes.
I'm a bit cognizant of time. I have one more question for you, which I would like to cover in 2 minutes. Is we talked about bringing these raw materials into the continent, into various countries. Also, we talk about uh, transportation of these products across the continent. I want to ask you from an experience of logistics, how aware are logistics service providers about these quality standards and the requirement that they have to follow on GSDP and specifications, transportation specifications of certain products, and the issues of theft and diversion of products that is quite also very, very common across Africa. Can you also touch very quickly on that?
Yeah, I think that's where we have got the biggest gap. We have even been communicating with WHO. If you look on the GBT tool on licensing, the focus is on manufacturers, wholesalers, and pharmacies, but the logistics providers are not fully catered for. If you look at the GSDP guideline, it just talks of them on outsourcing, but that's where the biggest challenge is, because the biggest risk happens in transit. Remember, these falsified products are manufactured somewhere. How do they get themselves into Africa? But the other main challenge also is a product that is quality assured. Everything has been done and it has been released into the supply chain. But because of mishandling, it can actually become a substandard. And usually regulatory authorities, they focus on importation, they take samples. But beyond that now, as it goes to the last mile, there's a lot that happens, temperature excursions, mishandling. And at the end of the day, at the last mile, we end up having substandard products being dispensed. So we have been looking at how do we bring in logistics providers. They are actually key. Even by definition of a supply chain, it talks about every player, including logistics providers, who in this case are the major culprits of bringing in falsified products. Because falsified products cannot just magically find themselves in Harare, in Nairobi, in Mombasa. Somebody is bringing them. So I think that's an area that we really need to focus on to ensure that any logistics provider who is handling a product is aware of the conditions, the handling conditions, the handling instructions, and even the condition of the transportation vehicle. Either it's a container or it's a temperature regulated container, and ensuring that the standard are maintained in transit where the risks are high and also where diversion happens.
Excellent. Thank you. Thank you so much, Wilson, for these key issues that you have flagged. Again, we're trying to go deep into what is causing these quality problems across the supply chains. Uh, the two key issues that we touched upon with Wilson was that a lot of locally manufactured products perhaps do not go through the same level of quality assurance that the imported finished products do. I may be wrong, but we are seeing some stats around that as well. And then another is whether the standards of GSDP and quality are being followed by all the transportation and logistics service providers across Africa. And this is something for you to also ask whether if you're working with providers. Now, with this, I would like to move to our next speaker, who is Mr. Timmy Omole. I'm sure a lot of you already know him. He's the executive director of IAPHL. Over the last 15 years, he has led and supported complex multi-stakeholder initiatives involving governments, multilaterals, donors, and other organizations. He has experience across Nigeria, other West African countries, and various global platforms. He's a pharmacist and he has master degrees in supply chain and international affairs. Now, Timmy, we have heard two different perspectives on different issues, again linked to quality assurance. Now, since you are on a daily basis working with people, I would like to ask you from the perspective of a supply chain workforce, where in the supply chain product quality risks are most likely to be missed, and why do these risks persist even when we talk about it quite often? So, from your experience, can you please put some light on this? Timmy? Timmy, we can't hear you.
Thank you, Sanjay. Can you hear
Yes,
me now?
yes, absolutely. Please go ahead.
Okay. Yeah. Thank you very much to everyone who had spoken earlier. I would just quickly show my face, and then I will turn it off so that I can be sure that my internet carries me. Yes, we have talked about issues of quality very much. And from the data that had been shown, it only suggests that if we count 4 persons here, two things can happen. One of us had at one time missed the opportunity to spot a quality issue of products within our supply chain. The other part is that one of us
Timmy, we lost you again. Oh, and I think we lost Timmy altogether.
I'm back.
Okay,
I'm back.
excellent.
I'm back.
All right.
Sorry, my internet has been unstable since the beginning of the webinar, but I hope it sustains
Yes.
enough. So I stopped at the point where I was making the instance of how important quality issue is, and then how it is also possible that 1 out of 4 supply chain professionals sees quality issues and could not identify it at one point, and it slips by and eventually gets to the patient by the same statistics that Collins had mentioned earlier. So it bears the question that, okay, if this product follows through the supply chain and eventually gets to the patient undetected or unspotted or removed from the system, that means the people who manage the system need to do something. What are the things? Now, to the question of where we have the most missed opportunities in identifying or spotting the quality, it is clear from most research and experience that down the stream of the supply chain is where we have the most problem. Why is it like that? It is where we have most exchanges of commodities from hands to hands, from system to systems. And it is in that place where we have the least effort in ensuring that people are empowered in terms of competence and authority to take actions. So one key issue is around the know-how of the people at the downstream, be it at the dispensary, at the warehouse, in transportation, like Wisin had mentioned, that in transit, a lot of issues of quality happens. But how empowered in terms of know-how is the driver who carries a vaccine from point A into point B, or from a warehouse A to a dispensary A, to ensure that these vaccines remain in a particular cold chain condition to sustain its potency to the last mile. We don't talk so much about that, and it takes from what Bonnie said, trust and responsibility for a person to understand what he needs to do at the time and take the decision. That is on one side. On the other side is the fact that when people are even empowered to take this decision, are they, I mean, to understand this decision, are they empowered to take those decisions? Because take, for instance, the issue around emergencies. Maybe because of Ebola, commodities are being moved towards the places where we have Ebola right now. And you are in the you are in the heat of the response, and you are now torn between making product available for emergency and also ensuring quality. It is neither one or the other. It is both that has to go. But we see most of the times the supply chain is orchestrated to support the fact that you make sure that the product gets to the point where they are needed, because that is the most visible metric that is measured, or that is the only available metrics that is even measured in most places. So it persists because there are no education or empowerment for people to support it, and there are no system to empower people to take decision where they are needed. And when those decisions are taken, are they protected? So if I stop commodities from moving to, say, Ivory Coast or DRC for Ebola, and then people continue to die, and I state the fact that it is because of quality that I stopped the product, will I be justified? Will there be a law that protects the supply chain officer who does the right thing by stopping it from getting to the people? Or he will be crucified because he did not allow products to reach the last mile. So those are the critical points of missed opportunities to support issues of quality. Again, when we look at the very minute part of supply chain, I take the case of a warehouse. Usually we have a warehouse quality officer who takes care of everything about quality. But we know that the business of quality within the warehouse does not lie within the purview of only the quality officer. It goes far beyond that because it takes the work of everyone, from the housekeeper, the person who manages the temperature, the person who manages the supply of power, the person who is the inventory manager or the warehouse manager, to be able to spot and report these kind of issues. So one other key issue is the fact that we do not orchestrate reporting from every touch point to be able to be seen at the center where a more robust decisions can be made. So these are the reasons why we have issues of quality persist and are common in the downstream. One, we do not have enough education. Education, I mean empowerment to understand the basics. What is quality product? Then what do we need to see to be able to tell that this product might be signaling a quality issue? Then two is we are not empowered. People at the downstream are not empowered to or incentivized to take decision and stop quality issues before it reaches where it causes the most damage. And again, there are no reporting channels, system that both takes the quality issue to the center.
Okay, I think we have lost Timmy, but I think he was at the final leg of his talk. I think he has
Yes,
mentioned. Sorry,
and I
Timmy,
am
I'm a
back
bit,
again.
yeah, I'm a bit concerned about time, so I'll just quickly summarize what you were saying before I go to Dr. Joseph. So thank you so much, Timmy. I think you've answered my second question in a way which I wanted to ask, if time had permitted, that what is limiting supply chain teams or even clinical teams to act on quality concerns? And I think you have already mentioned some of these things which are about ability to know what is a problem, the issue of training, the issue of coordination. I think you've already mentioned all those things. I think this is something for all the members in the audience to reflect upon, that are you able to successfully identify, document, and talk about quality problems that you see in your daily basis, in your daily work. And to me, I think that is a very powerful point that you have flagged to all our audience members. Now, with this, I would like to go to our last speaker, of course, not the least, Dr. Joseph Murillo. Now we have heard different perspectives, more at a policy and an advocacy level. Now I would like to invite Dr. Joseph to talk about it more at a level where uh, quality is a premium and is checked on a daily basis. Dr. Joseph works at MEDS. He is a quality assurance specialist with supply chain and quality assurance specialist with international certifications in these areas. He is currently the quality assurance manager at MEDS, MEDS Kenya, which is also a WHO pre-qualified laboratory where he oversees the QA processes. I would also like to say that MEDS is one of the very few organizations who has a GSTP accredited warehouse, a WHO pre-qualified laboratory, and a very robust transportation processes within Kenya. And MEDS are a part of EPN's broader pharmaceutical network. I think together with a few other organizations, MEDS is also involved in pooled procurement. So, Dr. Joseph, since this is what you do on a daily basis across the faith systems within Kenya and other neighboring countries, uh, I would like to ask you, in your experience, how has poor quality of products affected health services within these faith-based systems to start with? So that's my first question. If you can respond to it quickly, then I have a very important question for you because you are engrossed in this area of work. Dr. Joseph, over to you.
Okay, thank you very much, Sanjay, and good evening, good morning to everyone who is on this call. So as introduced, my name is Joseph Muriu, the Quality Assurance Manager at MEDS. And thank you for that question. Maybe to start us off, I know in the introduction part of this presentation, we were told about the difference between substandard and falsified products. And we were also taken through the effects that this, what we call the menace of the falsified and substandard products, the kind of menace that it has caused or the problems that it has caused in the healthcare systems. So maybe just to inform us that those effects that you would get in a public institution or public healthcare system, the same ones you get in private healthcare systems, but it's also similar to what you get when those falsified and substandard products get their way into the faith-based healthcare system. So the kind of effects that you'd get, they are the same. Maybe what could vary is the numbers or the number of falsified or substandard products that you get in either of those systems. Maybe just to quote one of the research that was done recently, in terms of preference, and this is based on the information that had been reported to the Pharmacy and Poisons Board, which is our national medicine regulatory authority here in Kenya. The researchers found that 60% of substandard and falsified products that had been reported in the PPB systems, 60% of those had come from public hospitals, and then around 26% came from licensed private entities, and then 5% came from the FBOs, or what we call faith-based organizations. So, and from where I sit as a quality assurance manager for MEDS, I'm proud to say that the reason why you'd expect to find lower numbers of falsified and substandard products in the faith-based hospitals is because MEDS plays a very significant role in containing this problem. Number one, and the most important, is that since inception in 1986, we have put up systems that have been enabled us to control this problem, both in the faith-based hospitals, but also in the public hospitals, because we also trade or we also distribute our products to the faith-based hospitals. And it was mentioned that we have an in-house laboratory, one of its own. I think the first one to get a combination of a faith-based procurement entity, also having an in-house laboratory which is pre-qualified by the World Health Organization. And also, we recently got the ISO IEC 17025 2017 accreditation for that lab. And the lab has very robust system. It has a chemistry unit, it has microbiology unit, and you're also able to test some of the medical devices, a few of them like gloves. So I would say that the kind of investment that you've put is the one that has helped fight this menace. In terms of the effects, just the same ones that were reported earlier: treatment failure and mortality and morbidity issues, because when these patients go into a faith-based health facility and they get, by chance, or God forbid, if they get a falsified product, it can lead to treatment failure. It can cause even death at the worst case, because some of these medicines are also toxic. Then the negative economic effect, I think Dr. Jaguga mentioned this one. Just to repeat that out-of-pocket spending, it's significant, especially in low and middle income countries, estimated up to 30.5 billion US dollars in low and middle income countries. You can imagine what kind of other investments or other healthcare services we could be providing if this menace had been fought in good time. And in Africa alone, we are spending up to 4 billion US dollars spending on these falsified and substandard medications. Of course, there's a low confidence in the healthcare system, and also the antimicrobial resistance, which I know we are going to discuss as we proceed. So the effects are the same, but the prevalence in the faith-based hospitals is lower, as reported in that research.
Yeah, and I think, like you said, a lot of credit needs to go to meds, at least in Kenya. I mean, I don't know about these stats in other countries, but I know in Kenya you have meds has put in a lot of investment towards this. But I would like to quickly touch upon the antibiotics side, the antimicrobial resistance issue that is also linked to poor quality or substandard products. Could you tell in a very simple way why there is a direct connection of substandard products to resistance, so that people who have not encountered this issue who are on this call today can also understand it, and also speak from the perspective of the communities that meds serve. Back to you, Dr. Joseph.
Okay, thank you very much for that question. And I still want to go back to what Dr. Jaguga presented, Dr. Collins presented at the beginning, that there's a differentiation of substandard and falsified products. So falsified is purely fraudulent, it's malicious, and it's someone who wants to cause harm. And then the substandard is, it could be an innocent mistake during the production, or maybe someone puts those products in wrong storage conditions. For example, during storage at meds or any other distributor, and maybe during transportation. Now, when you have, for example, an antibiotic or antimicrobial agent that is substandard, that means the content of the active ingredient is lower than the specified limits. So you'll find that this medicine, maybe they have a limit for this active ingredient to be between 90 and 110% of their label claim. Now, if you get something that has 70%, as was earlier reported, and you give it to a patient, it is not going to yield the concentration in the bloodstream that is sufficient enough to fight the bacteria. And what it does is the opposite. So that bacteria, when it is not killed by this antimicrobial agent, is able to mutate or to adapt itself so that it becomes immune to this medicine. And once, when now you give the patient the same medication at the right dosage, you find that this bacteria has already developed a defense system that medicine does not work anymore. And you're finding a lot of these cases, even with a very common antimicrobial agent, including ceftriaxone, which has been very common, commonly used antimicrobial agent in the country and the world. And we are seeing a lot of cases of this antimicrobial resistance. It's going to become a real problem when you have conditions that cannot be treated using the commonly available antimicrobial agents.
Thank you so much, Dr. Joseph. And of course, we will bring you back for some of the Q&A. This brings us to the end of the panel discussion. And as you heard from all these speakers, we touched upon the role of each and every individual, which Dr. Funda Funda talked about. Wilson talked about uh, the issue in local manufacturing and freight forwarders or logistics providers. Timmy talked about how accountability has to be set, and people, anyone, pharmacists, nurses, any professional needs to know how to check poor quality. And Dr. Joseph talked about how robust a system must be, and you see how many certifications meds has got and how robust are their processes, that they are able to check and minimize the prevalence of substandard medical products in the faith-based sector across Kenya and other surrounding countries. And he also talked about the issue of resistance that is directly connected to substandard circulation of substandard products within Africa. Now, with this, we go to Q&A. So you have the Q&A box. You can ask the questions there. There are some questions which are already being asked, so I will call them out and we'll see who responds to them. So the first one is someone from Bandile. He talks about what about visibility to buyers? How transparent are these manufacturers with their consumers on flagged packages from consumers? Is there a streamlined approach to enable bulk messaging or a community-based discussion on quality feedback on received shipments? Dr. Joseph, have you encountered something similar at Meds where you get some support from the manufacturers on what kind of messaging has to go to the consumers, or this is something not that Meds does? I'm asking you because I think this is directly linked to what Meds is doing. If you think you can answer this question.
Okay, thank you for that question. So I would say that we have a very good interaction with the manufacturers that we deal with. And during the assessment, we look at a number of things. I don't think they have any intention to be biased in their communications, because a lot of these communications, they are regulated. Remember, there's a medicine regulatory authority in each country, and including the advertisement, the labeling information that you put on a product, all of those are regulated. And for us, we look at the kind of information that you have disclosed, including on the insert. And if it's not based by any scientific information, then you are going to be, we are allowed to raise queries. And I believe it's the same process that the Pharmacy and Poisons Board follows for any of these communication or adverts that are given to the patients or the healthcare providers.
Excellent. Thank you so much, Dr. Joseph. Wilson, this next question is directly for you. It is asked by my laptop. I don't know what your name is, but the question is, for transportation of such type of medical products, it is must to have GDP certificate or use partners who have GDP that is enough. Could you briefly touch upon the importance of having a GDP or a GSDP certification for transport providers?
Yeah, GSDP or GDP is actually critical. Why? Because by definition, it talks of adequate control at every node within the transportation system. So once you are competent and you are GSDP compliant as a transporter, you'll be able to handle the product appropriately as it moves within the supply chain and maintain the quality. Thank you.
Excellent. Thank you so much, Wilson. Bonnie, may I please invite you for this question? It's anonymous, but the question is, what is your take on the country medicines regulatory regime regarding medicine supply chain?
Yes, thank you for that question. Well, I think we also need to understand that the regulator is a partner in access to medicines and enabling availability of medicine across the supply chain. So from that perspective, they are a strong part and parcel of the procurement and supply chain system. In fact, what most governments are trying to do is to encourage or to at least ensure that procurement, supply chain, and regulatory affairs are fairly interlinked so that there isn't any doubt around how these three institutions can or systems can work together. Because that's the way it's supposed to be. And I think if you are following what Wilson is describing, that there has to be stringency and assurances and interlinkages in everything that we are doing so that we can safeguard the health and safety of our citizens by making sure that these systems do work together. So regulators are very much part and parcel of these systems. They are not, they don't stand alone, and they are many of them are very keen to educate even the general public about the importance of quality, the importance of supplies, and in as much as extending all of that to the professional bodies in the health sector. Thank you.
Excellent. Thank you so much, Bonnie. There's a question which is very important. I don't know who should take it, but I'm just going to read out and then any of the speakers can decide who wants to take it. It's from Helen Mwanza. She says, in many developed countries, antibiotics are not available over the counter. Can similar controls be implemented in nations in Africa where antibiotics are currently accessible without prescription? And can the pharmaceutical supply chain be tightened to ensure responsible distribution and use? It's open to any of the experts.
I think this short answer is yes, it can, but how to get it done, it's a totally different conversation. We must recognize that we are still way apart from where those developed countries are. You will have to look at it from a holistic healthcare perspective. You need to check what is the percentage of people who are sick that seek healthcare services within a formal sector vis-a-vis the ones that seek outside of formal sector. So the conversation is didactic beyond just supply chain. It's a whole system approach that ensures that we have instruments and tools on ground to direct people to where they need to get help. And then you can also, by virtue of database, monitor who goes to where to get what. And that is still a problem. Like some of us have mentioned in the course of our conversation, there are already tools and technology that are being adapted to ensure that we facilitate this kind of thing. An example is the traceability tool that documents the points of exchange of medicine from manufacturing till the last point where it is consumed. If we have that for all of the medicines, all of the medicine within the system, it becomes very easy to regulate or dictate where and who gets what. But as of now, I think we are still far from that ideal situation. That is in my opinion. I will leave the floor for other contribution now. Sanjay.
Thanks, Timmy. I think I would take one more question. I know there are lots of questions. Please keep sending them. We will try to compile them and share responses with you. Dr. Joseph, I have a different question for you. I know you would have also answered the previous one, but given how MEDS has a very stringent quality management system, there's a question which is being asked by Abel Tekle, I think from Ethiopia. And I think what he's trying to ask is how to get QMS certification for medical device supply. Do you think you can answer that?
Okay. Yes. So maybe I can attempt to respond to that question. and say that for any supply chain organization that is dealing with either medicine or medical devices, the best kind of certification you can get, at least from my experience, is what we call the model quality assurance system for procurement agencies. And this has been developed by the World Health Organization, and there are entities, independent entities who do auditing and certification for this compliance. But even more important, even without formal certification, if you just ensure that you voluntarily as an organization adopt the principles that have been developed by that MQAS in terms of ensuring that your resources, your people, you have a pre-qualification process, even for medicine and medical devices, you have access to a quality control setup for testing, you have surveillance, and of course, you're using the right procurement methods, either closed, open, and very rarely open procurement methods. And then, of course, you do the right storage and distribution practices. You can, even without a formal certification, you can have a very good system for ensuring that you deal with the right products and also contribute to the fight against substandard and falsified products. And that is exactly what METS has adopted.
Thank you so much, Dr. Joseph. And unfortunately, I would have to stop the Q&A here. We will compile all the other questions and will attempt to send you the responses very soon. Can we go to the next slide, please? There's a reflection poll which is live on your screen, and I would like to share my screen here so that we can see the responses coming in. So if you can go to slido.com or scan this QR code, we would like you to write very quickly what is the one takeaway that you will be leaving this webinar with. Maybe one word or two words that you would like to write. Excellent. So someone has written quality needs consistency. So please have them filled up. And in the meantime, let me go to see what is next. Yeah, and I will quickly go back and check what people are saying. But in the meantime, I have some couple of transitional slides which I would like to talk about. So implementation assurance that we have been talking about. This is something that is a key service of CMCOMs who are pre-qualified for GMP and GXP. So GXP is all GP like GMP, GLP, GSDP, GPP. So if you are interested in understanding more about how to have better enforcement, contact Wilson Chandoba. I would also like to talk about the 10th Biennial Forum of EPN, jointly organized with PharmaConnect Africa and CHAZ. This is being hosted in Lusaka, Zambia from 5th to 9th October. If you're interested to participate, go to EPN's website or contact us. We'll provide more details. Next up, after I quickly show what people are saying, I would quickly invite Collins for a couple of minutes to provide us a quick summary of the webinar and what is coming next. And then I will re-invite Dr. Boniface to talk about a key premier event that is happening in Cape Town in a few weeks' time. But before that, very quickly, let's see what people are saying. Oh, wow, this looks amazing. So people are talking about health, regulatory, quality is not tested, quality is responsibility of all stakeholders, consistency, assurance, effort, coordination, collaboration. Please keep writing. Please give us some more words, point of views of what you think that you are taking away from this webinar. If you provide us really good information, this will help us generate the content for the next webinars that are going to come in this series. So thank you so much for providing us some more things, some more words to think about. But with that, I would like to re-invite Collins. I have shared my screen. I hope everyone is able to see it. Collins, very quickly, the summary of today's webinar. Collins?
Thank you very much, Sanjay, our moderator, our distinguished panelists, and all the participants who have this talk to this particular time. I hope you can hear me.
Yes.
So as we conclude this webinar, there are 5 key takeaways. Summarizing my presentation and the rich discussion from the panelists. So number 1 is that poor quality medical products are not just a product quality issue. They are a patient safety, public health, and the health systems issue. Number 2, the problem of poor quality products is a Pan-African and systemic problem, if you may call it, with common challenges that cut across countries, even though the scale and the context may differ. Thirdly, is that poor quality products include substandard, falsified, and unregistered products. And mentioned, each category requires a different response. Number 4, like we've seen, that quality can fail across the entire supply chain, all the way from manufacturing, importations to. And finally, that the root causes to poor quality medical products on our continent are interconnected, from weak regulation, fragmented supply chains, informal markets, economic limited accountability. So in terms of what we will have next in webinar 2, we will delve deeper into where does quality break down. I know we touched on this in this webinar, but we'll go deeper, discussing quality issues with regard to procurement, warehousing, transportation, examining the risks, etc., etc. So this is just a quick overview for what we will be covering next time. Otherwise, thank you, and over to you, Sanjay.
Thank you so much, Collins, for bringing back what was discussed today. And before all of you move away, I have 2 more small things from you. So first is, let me try to see where am I, because it's so difficult. I would like you to rate today's webinar, first of all. That question should be on the Slido screen now. You can also go back. And the question is, how would you rate the quality of and relevance, quality and relevance of today's webinar to your professional work? And while you are rating us, I would like to bring back, there's one more slide. Yes, the CPD certificate, if you have spent 70 minutes or more, we will send you the link and QR code using which you will be able to generate your certificate. And now, upcoming events, I would like to invite Dr. Funda Funda to talk about the 48th Annual CEPICS Conference 2026 that is happening in Cape Town. Bonnie, over to you.
Thank you very much, Sanjay. Thank you. And on behalf of our management team under Mr. Mbongeni and Lob, I would like to just read his message to you around this event that we are hosting in Cape Town. As the slide there says, this is CEPICS 40th conference, and it's also CEPICS 60th anniversary. And the theme is legacy, to celebrate that 60 years of work. And so it's legacy and leadership. So the program in Cape Town, which is on July 19th up to the 22nd, will focus on 3 streams, which is AI, digital and technology, operations, visibility and optimization, and thirdly, procurement, strategy and leadership. So at this conference, we have 44 speakers who have confirmed, and there will be representatives from companies such as Transnet, SOC, the Africa Continental Free Trade Secretariat, DHL, a company called Takealot Fulfillment Solutions, and SIVA Logistics. And on the health supply chains specifically, the program features a workshop that will be led by Sanjay. And thank you again, Sanjay, for your contribution and support. And also Dr. Andrew Brown, who should be familiar with many of us on this website. And there'll be other speakers from Salient Advisory, which is a Canadian firm, and also the Supply Chain Funders Forum from the UK. So you're invited to go to the CEPIC's website and register your participation. And there's a lot to learn, and particularly for those who will be in person at this conference. So thank you very much for giving us that opportunity to speak about this conference. Thank you, Sanjay.
Thank you. Thank you so much, Bonnie. And I would quickly go back to this poll. I see there have been 15 votes. I would request everyone to go back to this. So this is the QR code here. If you can quickly scan or go back to slido.com and tell us about how would you rate the quality and relevance of today's webinar. So far, it seems great. And we would really strive to bring other global and African experts to you in the upcoming webinars. I would like to thank the CEPICS team once again for hosting this. Special mention to Bongweni, who I'm not sure is here with us today, but the entire CEPICS team, and I wish them a great conference in Cape Town. Of course, it would be great because I'm presenting. Jokes apart. And sincere thanks to all the partners, Ecumenical Pharmaceutical Network, Richard and Brian and Diana, CM Comms, of course, Wilson, IAPHL, Timmy and his team, and of course, the team behind at Bskill, Muskan and Vinita and others who have worked tirelessly to bring you this rich content, CPD certified and free of cost. So Wilson is saying, I can't see the poll. Okay, let me go back. All right, so the poll is here back on your screen. I hope it is visible. So I've shared this again. So the QR code and the link, slido.com. Okay, so with that, I would like to thank all our speakers for today. Once again, Collins Jaguga, Dr. Boniface Funda, Wilson Chandomba, Timi Omole, Dr. Joseph Murio. Thank you so much, everyone. I wish you a great rest of the day and the week. And we will see you again in August for webinar 2 in this series. Bye, everyone. Thank you so much.
Thank you. Goodbye, everyone. Bye-bye.